And let's talk about PathCR. PathCR is an endpoint as a surrogate for overall survival. The majority of the trials showed the PathCR rates across the trials went from 17% to 25%. So let's talk about that patient who does achieve a PathCR. How do you think about that? And do you really, feel comfortable with that as a surrogate endpoint for OS?
I mean, I think it is, as you said, predictive of, longer, better improved survival. A lot of those patients, if we look at subset analysis, they have relatively high PD-L1 expression. So no surprise that, they have, a path CR. I think the question is in the perioperative strategy, if someone has a path CR, is there additional benefit to giving adjuvant, immunotherapy? And I think there probably will be some trials to answer that question. But I think, that it has, some implications and, who gets selected, for, adjuvant immunotherapy. I think the circulating tumor DNA clearance, once we validate that endpoint will be, useful information as well. And I think, that in combination with the circulating tumor DNA clearance, I think will be good clinical indicators in terms of, who's going to more likely have long-term survival, and who would benefit the most, from the immunotherapy and the perioperative strategy.
Great. And Coral, I'm going to bring this back to you as we talk about complete pathologic response. You said you had a preference for the perioperative strategies. What about patients who achieve a PathCR? Does that impact your postoperative management, your surveillance strategies, your decision to change your mindset? If you started thinking about perioperative, would you just pull back and say neoadjuvant only?
I thought about it. I haven't pulled the plug just yet. I think these cases we always bring to the tumor board, and I think the general consensus of our group is that we still go for it for the adjuvant therapy, even in patients with complete pathological response. I feel, like not 100% sure when I'm doing it, but I don't really have a justification to the patients to not provide it. So it's something that I really always have the discussion with the patients, but as a group, we tend to favor for now until we have better markers to really identify and help us guide. But do I think that maybe we're over treating some of these patients? I think we are.
I mean, I think with the update of Checkmate 816 from ASCO, I
Yeah.
feel really comfortable in having
Yeah.
a discussion with patients and avoiding additional therapy for a full year in patients who achieve a PathCR. I wanted to ask Mara and Robert, for patients who achieve at least what looks like a complete response on imaging, realizing that, sometimes you can't really have a great idea because of, the inflammation and lymph nodes can be a little bit plumper. But if patients look like they're achieving a complete response on imaging pre-op, for you, does that change anything about your surgical considerations?
No, I don't think we're there yet. I think that our imaging is not accurate enough for us to withhold what could be a really important part of someone's cancer treatment.
That's
Yeah, I agree with Mara. I think we don't have another clinical endpoint that we can use to determine, who's had a path CR and who hasn't without looking at the pathologic specimen. I wish there were a blood test or, some specialized imaging study that we could use to make those decisions. But unfortunately, we're not there yet, and we need to really look at that, pathologic sample, and see if there's still viable tumor. And the only way to only the pathologist can tell us that.
that's true. Good
I
point.
often tell patients who ask this question with all stages of disease, but anybody who's received therapy and they ask about whether they still need surgery or how can this be if, their imaging is one thing. I try to tell them that our imaging studies, our radiographic imaging is a snapshot and it's an approximation of what we believe the reality to be, but that the truth always lies under the microscope. And so that when there are discrepancies brought up, I really try to reinforce that the truth is what we see in the operating room and look at it under a microscope, and that our imaging is really, really good. And it's a great approximation. It's a great snapshot. But unless you're actually there and you're actually examining the cells under the microscope, that is the true determination of malignancy.